Hey, nurses and nursing students, want to reinforce pharmacology without boring old flashcards? Check out the Nursing Pharmacology crossword puzzle book from Meded101. It's an Amazon bestseller. It turns drug classes, mechanisms, side effects, and high-yield facts into fun, brain-boosting puzzles that help you remember what matters most. With over 2,000 questions and clues, it's perfect for study breaks, group review, or solo practice. This book makes learning pharmacology engaging. Grab your copy and start mastering meds in a way that's actually fun. Find it now at meded101.com/nurse. That's meded101.com/nurse. In this section, I'm going to cover thyroid disorders. So first off, the most common thyroid disorder is hypothyroidism. Just give you a little bit of background about diagnosis and some of the labs that are assessed here. Hypothyroidism is typically defined, or most commonly defined, as an elevated TSH and a low T4. From a clinical standpoint, this can often mimic some of the signs and symptoms of depression, fatigue, tired, but also can have some clinical symptoms, I guess, if you will, as well, where patients always feel cold, they might have weight gain, might have constipation, hair loss, dry skin. But again, that lethargy, lack of energy, just, low motivation, it can certainly mimic, some of the signs and symptoms of depression there, and then maybe they've got some other clinical symptoms with that. TSH should be considered a differential diagnosis in patients who are experiencing lethargy, fatigue, those type of things. Now, in many of my polypharmacy patients, obviously I'm trying to rule out medications that are sedating and those type of things as well that could contribute to that. But from a medical standpoint, we shouldn't forget about thyroid function as well. Normal TSH 0.5 to 6 on lab assessment can vary a little bit depending upon the lab. Hypothyroidism, we typically note an elevated TSH. So kind of counterintuitive the way the pathophysiology works out there. We can have what's called subclinical hypothyroidism, and that involves an abnormally high TSH. Usually it's very slightly elevated, but patients aren't reporting any clinical symptoms of hypothyroidism. Low T4 and normal TSH is possible. I'm not going to go through the different scenarios diagnostically on how that can happen, but just wanted you to be aware of that we may have some variations to that. But again, most common situation is an elevated TSH and a low T4. All right, so when we have hypothyroidism, we use medications to replace. That most commonly used medication is levothyroxine. Most common brand name you'll hear is Thyroid. This is a synthetic form of the thyroid hormone T4, which ultimately gets converted to T3 in the body. And from a nursing standpoint, from an administrative standpoint, there's a couple of things with administration that you guys really should know. So ideally, we want consistent administration of that levothyroxine. Okay? So same time, same fashion, we want consistent administration. The other big thing to pay attention to is binding interactions, and this is why, again, it all goes back to that consistent administration. So if we start a calcium supplement, an iron supplement, and we're giving it at the same time now as levothyroxine, that dose of levothyroxine is probably not going to be right, because that calcium or iron is binding up the levothyroxine in the gut, and we're not getting as much absorbed as we think we are. Okay? So really, really important to assess some of those over-the-counter medications, and particularly some of the vitamins and minerals that can bind it up. So most commonly it's things like zinc, calcium, iron, magnesium potentially as well. These can all bind up levothyroxine and reduce the absorption. Follow-up lab work, it does take a little while for that thyroid hormone or that replacement to kind of catch up and get patients to a normal level. So when we start levothyroxine, typically we're not going to check labs for at least 4 to 6 weeks, and kind of standard is in the 6 weeks to 3 month range for when we recheck the TSH and T4 levels and T3 levels. If switching between generic and brand preparations, extra monitoring is appropriate. Okay, so we can get a little bit of variation. Levothyroxine is a narrow therapeutic index medication. There's a touchy line, a fine line between the correct dose and too much and too little. Adverse effects are simply signs of hyperthyroidism. So if you understand the medical side of hypothyroidism and the medical side of hyperthyroidism, that can really, really be helpful in helping you assess clinically if that patient is more or less hypo or hyperthyroid. So adverse effect profile, hyperthyroidism, too much levothyroxine can amp patients up. That's the easiest way I remember it. Insomnia, anxiety, tremor, tachycardia, weight loss also can increase appetite as well. Prolonged suppressed TSH, one adverse effect from that. So if we give too much levothyroxine for too long, it can start to kind of wear down bones and increase the risk for osteoporosis. Usual starting dose of levothyroxine is 25 to 50 micrograms per day. Pregnancy, this is a very, very important patient population to remember and recognize. We may need to increase the dose of levothyroxine by 30 to 50%. Okay, so these patients have a higher requirement for that supplementation, because obviously the developing baby. So it's important to note that we should be monitoring those thyroid levels maybe a little bit more closely, and most pregnant patients will require a 30 to 50% increase in dose. There are some other products that may be used. Desiccated thyroid is actually a combination of T3 and T4. This is actually a porcine. It's derived from pig's thyroid. T3 has the most physiological action, the most kind of thyroid stimulatory effect in the body. Conversion, I guess I wouldn't memorize that if I were you guys, but we can convert from one to the other, levothyroxine to desiccated thyroid or vice versa. In general, guidelines do not recommend its use, and it's not required for most hypothyroidism patients, but in patients that were really struggling to get the appropriate dose, levothyroxine is not working quickly, we've given it an adequate trial, 6 months to a year, and patients are still struggling, it may be considered in those type of patients. All right, important drugs to remember that can affect thyroid function. Amiodarone can cause hypothyroidism or hyperthyroidism. In my experience, in most cases, it's going to be hypothyroidism. So we need to check TSH and thyroid function when we have a patient on chronic amiodarone. Lithium therapy, another one that can affect thyroid function. Rifampin as well. And GLP-1 agonists typically don't affect thyroid function per se, or at least it's not common. But we've got to remember in patients with thyroid cancer, GLP-1s do carry that boxed warning in that patient population that we typically should not use this medication. So that's a good one to remember as well as far as thyroid conditions go. All right, levothyroxine drug interaction, I alluded to them already. Keep tabs on this. So calcium, iron, magnesium, zinc, I didn't list those two, but another couple common GI medications that cause a lot of binding interactions are cholestyramine and sucralfate. So if you dose those medications too closely to levothyroxine, same thing can happen as with, calcium or iron, for example. We've also got some of the older anti-seizure medications that are enzyme inducers, such as phenobarbital and carbamazepine. These can actually chew up or metabolize that levothyroxine a little bit quicker, or the action of it anyway, a little bit more quickly, and that could lead to an underdose type situation if you have a new start of phenobarbital or carbamazepine, for example. All right, let's talk a little bit about hyperthyroidism. The most common type of hyperthyroidism is Graves' disease. Again, remember your body is amped up. We're getting too much thyroid hormone, anxiety, tremor, increased tachycardia, potentially arrhythmias as well. Weight loss can happen, certainly. Osteoporosis risk I alluded to as well. These patients tend to be hyperthermic, or they always feel warm. They get a little bit more sensitive to warmer weather and heat type situations. In severe cases, we can get bulging eyes is another potential effect here, often called Graves' ophthalmology. It's typically noted on a lab standpoint with a suppressed TSH. So that would be a below normal TSH, and then other thyroid labs are potentially elevated T3, T4. All right, so medications used to treat hyperthyroidism. So the thionamides is a class of drugs here. Methimazole is probably the most common agent I've seen used, brand name Tapazole. This inhibits thyroid synthesis by interfering with the oxidation of iodine. So remember that iodine plays a huge role in thyroid function, and it's important to have adequate iodine intake to make sure that thyroid function is going well. But anyway, this drug class inhibits thyroid synthesis by interfering with the oxidation, or essentially that utilization of iodine. This is done via inhibition of peroxidase. That's the specific enzyme that is inhibited. Typically, this will take a little while to work. It does have a longer duration of action than propylthiouracil. Propylthiouracil, or PTU, is the other medication that can be used. Biggest reasons why we generally prefer methimazole is it doesn't need to be dosed as frequently, and PTU has a risk for liver toxicity as well. And actually, this is a boxed warning. Thyroid storm. So this is basically an excess of thyroid hormone that gets to maybe a more severe life-threatening type state. Symptoms: tachycardia, anxiety, agitation, psychosis, and elevated temperature. Acute management of thyroid storm, we're going to use beta blockers. And if you remember from the beta blockers section, they can help kind of slow that heart rate down, okay, and make sure that anxiety and those palpitations are under control. That's what the beta blocker can help with. Propranolol is the most commonly used one I've seen. Corticosteroids may be considered as well. So in a severe life-threatening situation, you may see IV hydrocortisone. Antithyroid medication may be initiated and started here as well, a PTU or methimazole. I've spent over a decade teaching pharmacology, and I hope you enjoy this review and find it helpful in your studies. You can get full ad-free access to the Meded101 Nursing Pharmacology Review course at meded101.com/nurse. In addition, you'll get nearly 20 hours of ad-free, on-demand video lessons, downloadable slides which you can study from, over 40 cheat sheets and study guides, and practice questions to assess what you know. Whether you're preparing for exams or building real-world confidence, this course is designed to teach you things that matter on the test and in practice. Help support me in my mission to provide free, high-quality pharmacology education. You can do that by going to meded101.com/nurse and checking out the Meded101 Nursing Pharmacology Review course.